Thank you so much for joining us today. My name is Hillary Wall. I am a senior scientist from the Division for Heart Disease and Stroke Prevention at CDC, and I also serve as the science lead for the Million Hearts Initiative. I'm thrilled for this opportunity to tell you about our recently released Hypertension in Pregnancy Change Package, and I'd like to tell you a little bit about why we created it, who we created it with, and how you and your teams can use it. I have no disclosures. So as I mentioned, I'm the science lead for Million Hearts, which is a large national initiative launched in 2012 with a goal of preventing acute cardiovascular events in 5-year increments. Improving blood pressure control has always been a major priority for Million Hearts, but in 2022, we added a special focus on pregnant and postpartum women with hypertension. So I just want to take a second to run through some quick definitions. Hypertensive disorders of pregnancy is a term used by many to indicate pregnancy-associated hypertension, highlighted in the gray box on this slide. And this includes conditions like gestational hypertension, preeclampsia, and eclampsia. And you will hear me actually use the term hypertension in pregnancy, specifically because we want to ensure that chronic hypertension is part of the conversation. And chronic hypertension is pre-existing hypertension or hypertension that's diagnosed in the first 20 weeks of gestation. So hypertension in pregnancy includes both chronic hypertension and pregnancy-associated hypertension. And if you look in the upper right corner of this slide, in pregnancy, hypertension is defined as 2 or more readings greater than or equal to 140 over 90 millimeters of mercury, and severe hypertension is defined as 2 or more readings greater than or equal to 160 over 110. Severe hypertension is a very serious condition, and there is a whole quality improvement infrastructure that exists to deal with it, including things like perinatal quality collaboratives and the AIM bundles. But what's interesting is that until quite recently, obstetric providers did not generally treat chronic hypertension in pregnancy unless blood pressures were in that severe range, above 160 over 110. And that was really due to a lack of safety information related to treating blood pressures before that point. That is, until 2022, when findings from the Chronic Hypertension and Pregnancy, or CHAP trial, were published in the New England Journal of Medicine. And you can see this is a summary, a research summary from that journal. And in this study, researchers randomized 2,400 pregnant women with chronic hypertension. The intervention group received treatment if their blood pressure was above 140 over 90. The control group received antihypertensive treatment when their blood pressure was in that severe range, in this case defined as 160 over 105. And when we look at the intervention group compared to the control, there was an 18% reduction in risk of the study's primary composite outcome, which you can see on the box on this slide. That included preeclampsia with severe features, medically indicated preterm birth, placental abruption, and fetal or neonatal death. There was also a 21% reduction in risk of any preeclampsia in the intervention group. And there was no difference in fetal growth restriction between the two groups, which was the major safety concern. Now, generally, guidelines don't usually change with the publication of just one study, but almost immediately after publication of these findings, the American College of Obstetricians and Gynecologists, or ACOG, and the Society for Maternal Fetal Medicine, SMFM, issued clinical guidance recommending that obstetric providers treat mild chronic hypertension when blood pressure is above 140 over 90. And it is this practice change that we are most interested in supporting with our new change package. Studies have actually shown that it can take up to 17 years for scientific findings to be incorporated into care. And I think that we would all agree that we can't wait that long on this particular issue. Helping to improve care processes to support evidence-based interventions is really a foundational principle of Million Hearts, and that's where our new hypertension and pregnancy change package comes in. So the change package offers a menu of evidence-informed ways in which you can change care processes related to hypertension and pregnancy. And the bulk of the document is made up of the tables like you see here with the color-coded headers, which I'll explain in just a minute. And then you can see the column headings here. We've got change concepts. These are also known as key drivers. They're really just broad notions for change, and they give way to multiple specific change ideas, which are actionable implementation strategies. And then for each change idea, we've gathered tested tools and resources from clinicians in the field and national organizations that can help implement these changes. You can access the change package via the QR code or URL on this slide, but I'm going to quickly take a few minutes to take you through it. So I'm really proud of the fact that this document was co-developed by my division at CDC, the Division for Heart Disease and Stroke Prevention, and our sister division, the Division of Reproductive Health. And it was really done to bring together our complementary skills, knowledge, and expertise to tackle this cross-cutting issue together. We have also had the great privilege to co-author the change package with multiple clinical societies, including the American Academy of Family Physicians, the American College of Nurse Midwives, ACOG, the American Academy of Osteopathic Obstetricians and Gynecologists, the American Medical Association, the National Association of Nurse Practitioners of Women's Health, and SMFM. Now, earlier I mentioned there's this quality improvement infrastructure that's in place to address severe hypertension. And much of that is directed at emergency department and inpatient clinicians. But our change package is focused solely on outpatient clinicians. When it comes to chronic hypertension management, for the most part, we know what works. So the change package supports the use of the evidence-based interventions you see in gray, a few of which I'm going to explore a little bit further today. And we do that by using the implementation strategies you see in yellow, things like standardized treatment protocols, using data to find gaps in care and drive improvement, electronic health record reminders, and other clinical decision supports, and clinician and patient education and training. So I mentioned that each of the tables in the change package has a color-coded header, and they correspond to the 4 focus areas that you see on this slide. Key Foundations offers ways to change sort of fundamental policies and processes at the practice level, and includes things like identifying a clinical champion to make hypertension in pregnancy a practice priority. We also included a section on respectful and culturally safe care in this particular change package. Equipping care teams that you see in green lists strategies related to training and preparing clinicians and other care team members to focus on hypertension in pregnancy. And this includes supporting accurate blood pressure measurement. Then we have population health management in purple, which presents approaches to proactively monitor and manage hypertension in pregnancy on panels of patients. And this includes finding potentially undiagnosed chronic hypertension and using practice data to drive improvement. And then lastly, we have individual patient supports in blue, which lists ways that practices can support individual patients really at the point of care to better manage their hypertension. And we've included a robust section on assessing and addressing the social drivers of health in this particular change package. So let's just run through a quick example from equipping care teams to illustrate how to use the change package. So let's say your quality improvement team decides it has a need to support care staff to interpret blood pressure measurement for better diagnosis of hypertension in pregnancy. The change package offers 2 change ideas: providing training on the related clinical guidelines or using treatment algorithms to manage hypertension in pregnancy. Your team decides that they want to implement a standardized treatment protocol, and the change package then offers a number of different care pathways, algorithms, and flowcharts that can be used as is or adapted for your particular setting. So I've given you a lot of information, and the change package has a lot of information to review, and I think it can be a little bit overwhelming. So I wanted to give you a few places where you can start on your journey to optimizing hypertension in pregnancy management. And so accurate blood pressure measurement is of utmost importance. It's sort of the foundation to improving hypertension. And this is an infographic from the change package highlighting proper measurement technique. This is proper preparation and positioning. And this infographic holds true for both in-office blood pressure measurement as well as self-measured blood pressure measurement or home blood pressure monitoring. So if the only place a pregnant woman can have their blood pressure taken in your examination room is sitting up on the examination table, you might want to consider some office redesign strategies. That would be a really great place to start your quality improvement efforts. Also in the change package, you will find lists of antihypertensive medications that are indicated in pregnancy and during lactation. This is an example of one of those tables. And knowing that there are specific medications indicated in this population offers some potential quality improvement opportunities. Specifically, we can use, for example, electronic health record registry data to explore whether all patients with clinical indications of chronic hypertension are identified and diagnosed, and are all patients diagnosed with chronic hypertension managed appropriately. We can use data to see if there are gaps in this space. So I've mentioned preeclampsia a few times, and as you likely know, this is a serious condition. It involves both high blood pressures and organ damage. And there is a big opportunity to educate patients and their loved ones about the warning signs of preeclampsia, and the change package offers a number of tools and resources to do so. As you likely know, the only cure for preeclampsia is delivery, but you will recall from my discussion of the CHAP trial earlier that treating chronic hypertension before it gets severe can reduce the risk of developing preeclampsia. And another prevention strategy is low-dose aspirin prophylaxis. So ACOG, SMFM, and the United States Preventive Services Task Force recommend prescribing pregnant people with one or more high-risk features, seen in red on the slide, or two or more moderate features, seen in blue, low-dose aspirin or 81 milligrams of aspirin daily. Now, again, this list of criteria sort of offers a potential quality improvement opportunity where you use data to look for pregnant people who could benefit from a recommendation for aspirin prophylaxis. For example, have all of your patients with chronic hypertension been recommended or prescribed low-dose aspirin? It's a great place to start. And then lastly, I just want to finish up by asking you to please join us on July 11th at 1 p.m. Eastern for the Million Hearts Learning Lab, Hypertension in Pregnancy, Impactful Strategies and Tools. You will have a chance to hear from clinicians in the field who are implementing strategies in the change package, much as I sort of outlined today. And you'll hear from folks who are making improvements to care for patients with hypertension in pregnancy. And it's a great place to ask questions and learn lots of tips and good pearls. So here's my email. Please feel free to reach out if I can ever be a resource, and I will say thank you.